Okay, so first of all, just thank you everybody for attending tonight. Before we get started, just a reminder, we have a number of programs coming up in April and May, so you can check them out at www.finkelsteinlibrary.org/adult-programs. I will be letting people into the program as they arrive. And just please be mindful, since we are recording it, to make sure you're on mute. And, if you have questions, you can save those till the end, or you can put any questions in the chat, and we can get to them as we get to them. And on that note, I'd like to welcome our presenter tonight, Sunny Mitchell, MD. She's a board certified, fellowship trained oncoplastic breast surgeon. Hope I got that right. And has extensive experience working with high-risk breast patients, breast cancer populations. She is currently the medical director of the breast center at Monefiore Nyack Hospital and has previous experience at hospitals and universities around the New York area. She's also a pioneer in the field of oncoplastic breast surgery. So pretty much she knows what she's talking about. Anyway, let's go ahead and give this over to Dr. Mitchell and we can get started.
Thank you so much. Thank you for having me. What I've done is I've put together a few slides to cover the topic that I've been asked to present, which is breast cancer prevention. I've left plenty of time at the end for questions. So please feel free to, keep those in mind. Were we going to do the pre-question poll? Kyle? Okay, so we'll go ahead and continue then. Kyle, I believe, there we go. Okay, so breast cancer in general is a cancer of the breast, of course. It's very detectable by routine screening, such as a mammogram. Oftentimes, a mammogram is accompanied with an ultrasound as well. Standard of care recommendation is to have that annual screening mammogram and often an ultrasound as well, typically starting at the age of 40. When you are at higher risk, we oftentimes start earlier, typically 10 years prior to the youngest person in your family who's ever had breast cancer. And then depending upon if you are gene positive, we move that timeline accordingly. Breast cancer in of itself is highly treatable with an incredibly good prognosis for the majority of breast cancers. So the key is to try to detect it as early as possible. So it turns into a very treatable event, which you get treated, and you move on with the rest of your life. How treatment works these days is much different than it was, excuse me, 2, 5, 10 years ago. A beautiful thing about the field of breast health and breast cancer is that there's such a tremendous amount of research that put into it that the standard of care is continuously adapting and improving. So this is a bit of a busy slide, but elements that increase the risk of breast cancer. And all of these slides are what the medical field uses the NCCN guidelines, which is the National Comprehensive Cancer Network breast cancer. These guidelines are specifically for breast cancer risk reduction. These are the metrics that we use to assess risk. So a family history of breast cancer in men or women, and depending upon the age that family member had breast cancer, puts our radar a little different as to the potential for genetic susceptibility, being positive for a gene such as BRCA1 or BRCA2, or a number of other genes that we found to be associated with breast cancer. Increasing age, we know that the standard most typical time period that women get breast cancer is about 65, 70, 75, 80. It's a very common time to get breast cancer. Ethnicity, we know that if you are, for example, of Ashkenazi Jewish ancestry, Eastern European, that there can be a risk of carrying a gene BRCA1 or BRCA2 up to out of 1 out of every 40 women. So that's something that we keep in mind to help really promote breast health, breast awareness, and uh, utilization of screening. Lifestyle factors, we know that if you're overweight or have an increased BMI or body mass index, that's a risk for breast cancer and other cancers. Alcohol consumption, any alcohol consumption. So the standard recommendation is to limit alcohol. Current or prior estrogen and progesterone therapy. More significantly, the increased risk is associated when you are postmenopausal and you're taking estrogen, which a lot of women do take, and it is completely appropriate for a lot of women to take. Once that is taken for about 8 years or more, that is associated with an increased risk of breast cancer. So we just need to be aware of that. Reproductive history, these are pretty old metrics, but they still play out. If you get your period younger and you go into menopause later, um, not having children or having fewer children, um, and if you have your first child at an older age, basically what all of these factors do is affect the time period of exposure of estrogen essentially to your breasts. Other things that are associated with the increased risk of breast cancer include having breast biopsies that have the word atypia in them. So, atypical hyperplasia, a flat epithelial atypia, or a biopsy that has shown LCIS. LCIS stands for lobular carcinoma in situ. It's a horrible name. It is not cancer, but what it is, it's a marker for increased risk of breast cancer. Um, Number of prior biopsies along with that, having dense breasts, which is very common and pretty typical for most women, and prior mantle radiation therapy or a therapy to your face, neck, chest, also can increase your risk of breast cancer down the road. So oftentimes when you go into your gynecologist or your primary care or your breast surgeon, they will assess your risk. And two of the most commonly used models, something called the Gale model and the Tyrer-Cuzick model, the questions that your gynecologist or your primary care, your breast surgeon may ask you in order to figure out your risk based off of these models might include prior breast biopsies, all of the questions that they normally ask you. So elements that decrease the risk of breast cancer, and one would be a prior oophorectomy, which is having your ovaries removed. And this really applies to women that are at higher risk of breast cancer, such as BRCA1 and BRCA2. Um, Prior risk reducing therapy, what this refers to is having completed a trial or taking a medication like tamoxifen or relaxafen. These are medications that are well known to reduce your risk of breast cancer and reduce your risk of a recurrent breast cancer. In general, the risk reduction is about 40%. These medications in this metropolitan area where we have a lot of resources are typically prescribed by medical oncologists. If you're taking it to reduce your risk of cancer, it's called chemoprophylaxis. Exercise has been well established to decrease risk of breast cancer along with many other cancers. And breastfeeding has also been associated with decreasing risk of breast cancer. So, genetic counseling and genetic testing, uh, this is offered to any woman or many men as well who are at high risk, secondary to a strong family history, or have a family history of family members who've had a premenopausal breast cancer or breast cancer in their 30s, their 40s, their 50s, have a strong family history of ovarian cancer. Any woman who is of Ashkenazi Jewish ancestry is definitely a candidate if they desire to go through genetic counseling and genetic testing to assess their risk so that they know what tools they can use in the current era to help reduce their risk of breast cancer. Anyone diagnosed with a breast cancer is offered genetic testing these days as well. It's much more accessible to everybody. We have a great genetic counseling team right down the road at our hospital as well that I know a lot of our community take advantage of. It's incredibly accessible. So risk reducing therapy for all of us would be breast screening. Breast screening involves a yearly mammogram. Many women will also be asked to have an ultrasound at the time of their mammogram. The key to mammograms is sometimes radiologists will ask for additional imaging. So they might call you back and take an additional mammogram. They might ask for an ultrasound if one hasn't been done, or a targeted ultrasound. The majority of the time, when additional imaging is asked for at this breast screening, it does not mean that you have breast cancer. It's just purely that the radiologist could really use more information to get a really good view of your breasts. Lifestyle modifications under risk reducing therapy include exercise. If you're able to do it, if you're physically fit, the NCCN guidelines and current data recommends a pretty vigorous exercise routine. So daily exercise, get your heart rate up. If you are not at your peak fit performance, but you're able to walk every day or walk several times a week, that counts. It's incredibly great for your health as well and your overall well-being. Risk reducing agents. This refers back to that tamoxifen or relaxofen that we spoke about. This falls into a category called SERM, or selective estrogen receptor modulators, which is a mouthful. But long story short, it reduces the estrogen delivery to your breasts. Risk reduction can be 40% with medications like that. A risk reducing mastectomy, or what's called a prophylactic mastectomy, is an option for women who are high risk, BRCA1, BRCA2, some other genes. And this would involve preemptively removing your breasts and having a immediate reconstruction. These days, we're able to do that in a manner that is often one-time surgery. For many women, the mastectomy, we're often able to keep the entire outside of the breast, so nipples are able to stay intact and have immediate reconstruction that day. Um, Oophorectomy, which is removing your ovaries preemptively. This again is for women who are at very high risk of ovarian cancer. Typically, this would be BRCA1 or BRCA2. If you have a BRCA1 or a BRCA2 gene, your risk of having breast cancer is not it's about 75% or so. It's not a guarantee that you will have breast cancer. It's just associated with an increased risk. There's also an increased risk of ovarian cancer with BRCA1 and BRCA2. It could be like around 45% for BRCA1 and around 17% for BRCA2. Men who are BRCA positive also have an increased risk of breast cancer. It's lower in comparison to the risk that women have, but it's definitely still there. While we're talking about BRCA1 and BRCA2 for the time being, because of the treatability of breast cancer and the exceptional screening programs that are available, about 50% of women who are BRCA1 and BRCA2 will opt for preemptive or prophylactic surgeries, and about 50% will not. They're both great strategies because breast cancer is very treatable when we detect it early. So the key is to continue with your annual, yearly mammogram and ultrasound, or just mammogram. And some women will have an MRI as well. So that plays into the level of risk for breast cancer that you have. So exercise when you're premenopausal, vigorously physically active is the standard, and that would involve, anyone who, if you go to the gym 3 or 4 times a week, or if you work out, or you play tennis, or you swim, or you bike, all of this counts just as physically active as you can be. Postmenopausal, daily activity is strongly encouraged, and data plays out that at least 150 minutes. So, what is that, like 2.5 hours at least a week? And this can be divided up at your convenience. But the key is to move, to be active. If you have any question at all about your ability to exercise, definitely talk to your primary care doctor, and they'll be able to lay out what your expectations can be. And if you don't have a gym, or if you don't have a bike, or if you want to, do it with minimal resources, of course, there are a lot of things you can do. Walk. There's some amazing hills in your area. Walking up and down those hills is tremendous. Push-ups. You can be very creative at the type of exercise that you're able to do. So risk factors that we can change. The key with breast health is to control what we can. So attempts at maintaining a healthy weight. This is pretty standardized based off of your height. Your body mass index is what your primary care or your doctor will figure out roughly, how much you should weigh according to how tall you are. And you probably have a good idea of that. You probably feel a lot better when you're within your weight. That's great for your body. That also has so many other effects as well. Improves, diabetes, high blood pressure, elevated cholesterol. Oftentimes, many of these things are markedly improved when we're at an ideal weight for ourselves. Physical activity, which we've spoken about a lot, which I think we've covered. Don't smoke. Don't start smoking. It's associated with a lot of cancers, as we know. More of a plant-based diet. If you're not a vegan, you do not by any stretch of the imagination have to convert to it. But if you just increase the amount of fruits and vegetables that you eat throughout the day, that's incredibly helpful. There's a lot of data that's gone into that. We also have an amazing outpatient nutrition program, who you would probably really appreciate hearing from them. They are experts, obviously, in that field, and can really give you an idea as to which foods, which fruits and vegetables are associated with a increased healthy diet. Limiting alcohol. We used to, there were a lot of studies that showed a few drinks a week, one drink a week, Now the standard of care is to just attempt to limit your alcohol as much as possible. Even a small amount of alcohol has been associated with more recent studies of being correlated with increased risk of breast cancer, and limit postmenopausal hormonal therapy. This, of course, will be a conversation with your primary care, sometimes your cardiologist, your gynecologist. Estrogen is replacement therapy is very helpful for a lot of women, but we do know also a caveat to that is when it is taken for more than 8 years, there is a definite association with an increased risk of breast cancer. So that's just something that we need to be aware of. Okay, so that has taken me through the slide deck that we have. I'd love to answer any questions that anybody has um, on
Okay.
breast cancer prevention.
There is one question in the chat so far. Did you want me to put out the poll for everybody?
Oh, that would be great. Yes.
Yeah, I hadn't done that, but well, let me do that first, and then we can answer the questions, I think.
Okay.
So here's this. Well, let's do the post poll. Okay. Okay, so this is just a poll of 5 questions that that they had given us. If you'd like to answer these, they're just true and false. So. Okay, is everybody seeing the poll? We got one. Okay, there we go. Yeah, it's just, I guess it doesn't do anything until maybe you do all of the questions. So, okay. Okay, I think that's everybody. So anyway, yeah, while this is going on, there's a question from Carol. There's a couple questions from Carol. One, can you see the chat? So,
Maybe if I stop sharing, then I would be able to.
no, I can just let you know what it says.
Okay.
So she says, at what age, considering adult negative mammograms, but having a sibling who did have breast cancer, is it acceptable to shift to mammograms on a more staggered schedule? My genetic studies for breast cancer probability have been performed with no abnormal results.
Interesting, very interesting and timely question. So the U.S. Preventative Task Force has really been encouraging over the past few years to not do annual mammograms and to do them starting at a little bit of a later age and for a shorter time period. That being said, every single medical society, including the American Society for Breast Surgery, do advocate for a yearly mammogram or yearly breast screening starting at the age of 40, and for some people younger, depending upon their risk, and continuing that on an annual basis until you feel that if you were to detect a breast cancer, you wouldn't do anything about it. So if you're physically fit or healthy, and you are in your 80s, you can still have breast screening. So once you get into a time period where you're later in life, and it depends on the individual, might be in the later 90s, might be in the 80s. that is a consideration that that you can definitely have. And the reality is what it comes down to is, if you were to detect a breast cancer, would you want to get it treated? So for the most part, everybody, the standard of care recommendation is to continue on a yearly and an annual basis. Did that answer that part of the question? So most breast cancer, to just expound on that a little bit, occurs in people who do not have a gene, like a BRCA1 or a BRCA2 gene that gives them increased risk for breast cancer. So most women who get breast cancer have no known or detectable gene associated with increased risk. And because breast cancer is so treatable, I would advocate, and the medical field advocates for annual screening, annual or yearly mammogram and ultrasound, or mammogram, some people MRI as well.
Okay. Yeah, so another question here is, are bioidentical hormones considered exactly the same as natural in a post-menopause state?
Yeah, it's interesting. Hormone, it depends on, there are a lot of uh, medications or pills or hormones out there that are labeled bioidentical, or a variety of names that may or may not be estrogen or estrogen and progesterone. With each of those, what I would do is, if you come across something that you're interested in taking, bring it actually into your primary care, your gynecologist, or your breast surgeon, whoever it is that you follow up with, and show them the bottle, or give them the name of it, and ask for their input. There is a significant uh, there's a wide disparity in what those medications are.
Okay, does anybody else have any more questions? Okay, if not, we can share the poll results here. And okay, are you able to see those, Dr. Mitchell?
Yeah, that's fantastic.
Okay.
I mean, clearly I'm speaking to a group of people who are pretty savvy and well educated. So hopefully you are able to learn something tonight, or at least have your current practice reinforced. So yes, breast cancer is very detectable. The way to detect it is prior to it being palpable. So when it's so small, you can't even feel it. It only shows up on a mammogram or an ultrasound, or a combination of a mammogram and ultrasound. That's exceptional. Which is why the yearly mammogram and ultrasound, or mammogram. Women should get a mammogram every 3 to 5 years. I had to put some kind of a question in like that, but it's highly relevant. So, I can't say that the person who said true is wrong, because that is what the US Preventative Task Force is recommending. However, um, none of the medical societies do recommend that. Why? Because, in a nutshell, breast cancer is incredibly treatable. The way that it's incredibly treatable is when we find it at a very early stage. And in order to do that, annual breast screening is still the recommendation. And then moderate amounts of alcohol do not increase risk of breast cancer. They do, actually. In I guess all of our definitions of moderate amounts of alcohol are different, but the reality is just try to limit your alcohol intake. The limitation of alcohol is associated with a decreased risk of breast cancer. Is that helpful?
Yeah. Couple, yeah, there are two more questions that were,
Okay.
you can scroll down.
I,
Yeah.
let me see if it
Um,
allows me to.
I don't know. I scrolled
Yes,
down, so I
yes,
don't know
yes,
if
yes, yes,
that's,
yes. Thank you
that
so
would
much.
help. Okay. Okay.
So light exercise is recommended to reduce risk of breast cancer. Uh, so actually vigorous, but we're splitting hairs here. So any exercise is helpful. If you're able to do vigorous exercise, please do attempt that. If there's any question about it, just talk to your primary care, ask them what would be healthy and safe for you to do. Breast cancer is typically not treatable. Well, that is truly false. Breast cancer is typically incredibly treatable, to the extent that even when people are BRCA1 and BRCA2, about 50%, as we were talking about earlier, opt for preemptive surgeries and 50% don't. And that is all okay, because we are more often than not able to detect breast cancer at an early stage when you do annual or yearly mammograms, which results in great treatment for the most part of breast cancers, turns them into a treatable um, diagnosis, which is very, very encouraging. Any other questions?
Um, I kind of had one out of, I guess, out of curiosity based on what you had said before.
Yeah.
And my wife just turned 40. So hi, Jennifer, she's on. But you were saying, so like, you were saying physicians recommend like yearly. And obviously that, the more you could do, probably the better, of chances of finding something. But then what I don't know, committee or whatever it was recommending 3 to 5 years. Um, is there, like, as far as like insurance companies go, is there any kind of like pushback from them to like, to say like, you shouldn't have one every year, or like, things like that?
Yeah, and that's thank you for
Um,
bringing that up. That's an excellent question. So, I have not heard of anyone being refused a
mhm,
mammogram, a screening mammogram on a yearly basis.
mhm.
Yeah, I hope that does not come into play. Um,
Yeah, right.
yeah, yeah. But I would, the way I would look at it as is, um, breast cancer is very treatable, especially when diagnosed at an early stage, meaning when it's small. And the way that we're able to detect it at that point is by doing a yearly mammogram. So, statistically speaking, most people will not get breast cancer, which is great. But if you happen to be one of those people that does get it, I would much prefer for everybody to have a breast cancer that's detected super early, very small, very treatable, so that the diagnosis and the treatment turns more into a nuisance versus a bigger deal. So that's how I would look at it.
Okay, thanks.
You are welcome. Good question.
Okay, yeah, as Carol says, she finds just the opposite. Her insurance practically insists on the annual screening. So,
Aha, good.
right.
Good. Yeah. And it's not something, it's not something I would be fearful about on a regular basis. I would just incorporate everything that we talked about into your regular regimen of living life, which I think most people do. Try to stay as healthy as possible. Once a year, get a mammogram. And then consider your risk. You can have that assessed with at our breast center. We have an amazing genetic counseling and genetic testing team. You can talk about it with your gynecologist. They can get you plugged in as well. It's often very, very easy. You can do genetic testing if you want. You don't have to do genetic testing to. You can get a sense of your risk even prior to or without genetic testing.
Okay. So if there's no other questions, did you have anything else you'd like to add?
I think that's about it. I just wanted to say thank you so much for asking me to your library. And I look forward to the day when we're able to do it in person. If that works, if that's feasible, we'll do it. And I know that our community hospital is well used by the community, and we have a tremendous amount of resources, as I think most people actually in the community are already aware of. But let us know if there's anything that we can do for you, or if you need further guidance in how to get the questions answered that you have, or the tests done that you need performed.
Okay, yeah, and thank you very much for coming and doing this program for us, and also to Sandra for helping me to set this up and getting in touch with you and all of that. And yeah, for the people that came in a little bit later, we are going to be fairly soon having programs back in the library after a couple years. So summer, start looking for some programs here / hybrid, also with Zoom. So some good news. So anyway, let me stop this